Hello dear student, this is Dr. Sehar from DentaBest, your best online mentor for the preparation of INBD, ADAT and AFK exam. Please subscribe to my channel on YouTube and follow me on Facebook, Instagram, TikTok, LinkedIn. Please do visit my website at dentabest.com where I am providing personalized and self-study smart learning programs at a very affordable cost for all my dear hardworking students. So today, we are going to take topic from the subject oral surgery. So let us try to understand first. So today in this oral surgery video, we are going to take topic of fracture. That is actually one of my favorite topic in oral surgery. So first of all, we should know what is a fracture. So fracture is, we can define in simple term, it is just a discontinuity in the bone, right? So when there is a discontinuity in your bone, that is a fracture. So there are different types of fractures we have, like we have a simple fracture or a closed fracture, which does not have any communication with the external environment. Then we have the compound, open or complex fracture that communicates with the outer environment. You have more chance of infection here. Then we have comminuted fracture. Comminuted fractures are those in which fracture is happening in multiple pieces. Then we have the green stick fracture. Green stick fracture is more common in children, where bone actually doesn't break, it bends, because bones in children are very flexible. Then you have the pathologic fracture. Pathologic fractures happen like in osteoporosis. You have some underlying disease, your bones are very weak, leading to pathological fracture even without trauma. Now let us see, this is the picture of the mandible we can see here. And if you talk about the mandible, which is the most common site of mandibular fracture, your answer is neck of condyle. Around 30% of fractures, they are at the neck of the condyle. The second most common site of mandibular fracture is actually at the angle. Around 25% of fracture, they are at the angle. Then comes the body, parasymphyseal area, and the least common site of a mandibular fracture is the coronoid process that we have here. So mandibular fracture definitely can be seen on pano, but to visualize a fracture, you need at least two radiographs. One of them, pano, Townes view, PA skull, lateral oblique, and when the patient has a mandibular fracture, malocclusion is a very common sign of it. Now, if they ask you in the exam that which is the most common site of facial fracture, your answer is nasal bone. The nose fractures, they are most common. And the second most common is definitely the mandibular fracture. So when you are doing the open reduction for the unfavorable fracture, you are surgically exposing the fracture site. And then you are directly putting the plates there, screws, wires, and bringing the fracture segment together surgically. But let's say the fracture is favorable, like your condylar fractures. So if the condylar fracture is a favorable fracture, a simple fracture, then you can do a close reduction. Close reduction is when you're not surgically exposing the site. No. What you are doing is just doing the IMF wiring, intermaxillary fixation, and you're immobilizing the maxilla and the mandible together, both the maxillomandibular teeth together in occlusion. So slowly it is going to heal your condylar fracture. But when you do the close reduction, you don't do the immobilization of the jaws for more than 2 weeks. Why? Because you don't want the ankylosis of the condyle. But yes, as we discussed that if open reduction is done when there is a fragment. So you can see the protocol for mandibular fracture treatment. So you need only level A intervention or a conservative management if your fracture is just isolated, minimally or not displaced, and does not disrupt the occlusion or the mandibular function. But level B intervention is doing the stabilization, non-surgical stabilization, in case if you have some degree of mobility in the displaced segment. However, fracture is still not disrupting your occlusion or function. But level C intervention, it includes using your arch bars. Now, displaced fracture interfering with occlusion or function. That's when your direct open reduction will be required. But if it is a displaced, unstable, non-condylar fractures that is interfering with the occlusion or function, then you would require level D intervention. So, for the condylar fracture that occur in conjunction with another fracture, the non-condylar fracture you are going to rigidly fix by using your arch bars, plates, screws. For the physical therapy, it will help for the condylar fracture. You can see one more flow chart here. So, mandibular fracture, if it gets through the trauma, if the angle or symphysis, as I told you, you need the surgical treatment, that is the open reduction. But if it is a condylar fracture which is favorable, it depends upon if it is intracapsular or it is extracapsular. So, intercapsular fractures mainly affecting the condylar head, you can do open treatment followed by functional therapy like doing the IMF wiring, or open reduction with or without internal fixation, or even the endoscopic surgery can help in fixing it. The condylar neck fracture, close treatment, usually without open surgery. For the condylar neck fracture, you use mainly the close treatment, that is doing the IMF wiring without doing any open surgery or without doing any open reduction. So that's all about the video today. Please keep watching my channel on YouTube. Thank you so much for watching this video. Study hard but study smart.